up here. Maybe I should spread it out to 2 spots.
Oh.
Hi. All right. In this group of, like we normally have 16, I think we only have 15 today. In this group of people, we have a whole lot of people who have had cancer. Okay. Cancer is widespread. It is stuff that we understand and we know, that we've seen, that we've had impacts. My big thing that I want to tell you is every single one of these people had a different treatment. Okay? So we can't think of cancer like AFib. We know we're going to do like amiodarone or Pacerone, and we're going to do, you know, an anticoagulant, right? We know we're going to do those things for AFib. It's the same treatment relatively universally for our patients, maybe an adjustment. Every single one of these patients had a different treatment. Every single one of these patients had a different staging, a different aggressiveness. They were probably different ages when they got this. Okay. Like Andrea, she was a hockey mom. She was 40 when she got cancer. She died at 43. Okay. Uncle Skip, he was a longtime drinker and smoker, good old Navy boy. He died in his 60s of cancer. All right. So every single one of these people has had different cancer at a different age. My daughter's friend Harper had cancer at age 7. Okay. She battled and won, which I'm not sure how much I like those kind of terms when it comes to cancer, because I don't think cancer is something we can always win. All right. It's a race that we may or may not be able to finish. And I really hate the idea that, oh, if you just tried harder, if you just worked a little bit more, you could have beat it, right? So that's something that's a kind of an ethical or just a thought conversation. So what I'm going to do is I'm going to teach you guys generals about cancers. Okay. I'm going to keep a real broad view of it. If you have a specific question related to someone who you cared about or loved or cared for, please come and ask me. Okay. I was an oncology nurse for a year. I loved it. I love my oncology patients. They're amazing people. I think I've only ever had one mean cancer patient. If you ever want nice patients, cancer patients will be that way. They're just some of the nicest people you'll ever take care of. I always say, like I'm at chances of getting cancer just because I'm a nice human being. Like if you're nice, your chances seem to go up. If you're a jerk, they seem to be down here, right? So no, that doesn't seem to cause it. But we are going to talk about some of the causes of cancer, because there are some links. There are some things that actually cause cancer that we know of. All right. So let's see if this will actually work with me today. And you can see that I put up, nope, come on, flip over. There it goes. You can see that I've put up a bunch of different ribbons. Okay. Every cancer has its own ribbon. It gets really hard to know which cancer is which ribbon anymore. And now we have like suicide awareness ribbon, and it's like, oh, okay, is that non-Hodgkin's lymphoma or is that suicide awareness ribbon? So the colors start getting mixed and blurred around. But it does show you how many different types of cancer are out there. If you've got a cell in your body, you pretty much can get cancer of it. Okay. So one of the things that we know causes, let's see if they'll let me do this, is genetics. All right. Genetics is a cause of cancer, right? We've linked, there's been lots of news reports about BRCA1, BRCA2, which are the breast cancer genes. Okay. There's a prostate one. I mean, we are in the infancy of linking genetics to cancer. All right. How much would you guess that genetics is of cancer? Like, how many would you guess of our cancer patients, it's genetics that caused it? Any of them? Okay, 50? Huh? Over 50%? I hear 70? It's 10%. 10% of our cancers are caused by genetics. And here's the reason why. In order to cause cancer genetically, so this is my really bad chromosome here, okay? On your chromosome, you have to be born with the genetic mutation already, all right? And so what happens is you get one side of a chromosome and you're already born with that genetic mutation, okay? In order for that to finally glitch and flip back over into full-blown cancer, it has to be on both sides of the chromosome, okay? So while yes, probably a lot of us have different genetic traits, and I think as we age and we get more experience with genetics, we will see that genetics plays more of a role than we think it does, because I'm pretty sure that's probably more of a role than what we think. It is, as of right now, only about 10%, okay? Meaning that something else is causing all these wonderful people to get cancer. What do you think it is? Okay, so it's a mutation, right? It's all of it. It's chronic irritation. The biggest cause for cancer is chronic irritation. Now, I don't think that Harper, who was 7 years old, had chronic irritation to give her leukemia, right? That there was something in there already. But an 80-year-old who has leukemia, first thing I ask when a patient comes in with leukemia is I go, are you a farmer? Okay? Because what do farmers expose themselves to? Pesticides, chemicals. I had a farmer that used to come in, or that came in, and we were trying to figure out why. Why did he have cancer? So, like, he had just horrible leukemia, like to the point where when we drew back his blood, it was the wrong color. Okay? Because with leukemia, it's cancer of the blood. Okay? And so when I went to pull back blood to get a blood draw from him, his blood was like maroon instead of nice red. Okay? Probably the color of Keisha's shirt a little bit. Like that maroon, dark color. Like you knew, and it was thick. It was hard to pull back. Okay? His white count was probably over 40 to 45,000. He had that many white cells blast into there. Okay? And so we talked to him, and we asked him at one point in time, like, okay, you're a farmer, so you're exposed. And we asked him, well, how did you work? What protection did you wear when you worked with those pesticides? And he's like, I didn't need any protection. It didn't hurt me the first time, so it's not going to hurt me the 20th time, right? Well, what he would do is he'd stick his arm in whatever vat of pesticides and use his arm to stir it up. Okay? Chronic irritation is the main cause of cancer, all right? Because cancer is a genetic mutation. Remember, on that chromosome, we got to have it on both sides. So it's a genetic mutation. How many of you guys have had to reboot your phone or your computer because it glitched and it's not working, right? I'm not even talking today. I'm talking in the last week, month, year, right? Okay? That is all that is happening here when it comes to cancer, is that there is some sort of chronic irritant that has messed up that cell and that genetic makeup of that cell. And so then it starts doing what it shouldn't. All right. And what it shouldn't is, so there's a lot of things that have to go wrong for this to happen. So you have cells, okay? And these cells all know, oh, I should have picked a solid color, not a glitter color. All these cells all look around and say, yep, you are like me, you are okay. And the cell even says, I am like you, I am okay. Okay? So something happens in here. I'll pick green, I'm not really dying. Where one of these cells starts to not look like the others. Now, cells have a self-terminate mode where they can go, nope, I don't look like the rest of you. I need to just ixnay myself, and it causes like cellular suicide, right? It dies, and it goes away. The other cells have the ability to look at it and say, you are not like us. We are going to snuff you out. Okay? So that can happen. Those two things are safety mechanisms, because if you guys think that in our billions of cells that we have, it goes right every single time, right? It doesn't. It's just like our software. It's just like our technology. Every once in a while it glitches, and we have to just reboot it and retweak it. Be like, start over. So we get rid of that cell and we start over. Well, what happens is that cell all of a sudden says, well, I don't really care that I'm not like you. And I don't really care that I don't have enough food source to grow. And I'm just going to start growing out of control. So now that chronic irritation has caused genetic and cellular damage to one cell now that is massively replicating, okay? And this is really important for us to understand because it makes us understand our treatments. Our treatments are based off of killing rapidly growing cells. Radiation and chemo, that is what they kill. Why can't you have a baby and be working with some of these chemicals? Because that's what those chemicals kill, is rapidly growing cells, okay? And so it's really important for us to understand that link to it, because then it'll make us understand why we have the side effects we do, right? So now we've got this growing. And the really cool, like guys, I'll be honest, if I go too deep, I can totally like geek out on cancer. Like it's really awful to say that I love cancer because it's a horrible, horrible disease, and I've watched family members die of it and loved ones. But it's really cool when we realize what it is and how simple of an issue it is, okay? But yet how hard it is to take care of and how unique it is to every single one of those people, okay? So chronic irritation, why do we in the Midwest have more colon cancer than they do on the coast? Meat. We like our meat and potatoes here, right? We like our starchy foods and our steak, and our gut is not meant to digest that. We didn't evolve to digest that. We evolved to be omnivores and eat more berries and fruits and grasses and stuff like that, and an occasional meat, okay? I'm not saying don't go out and eat your steak. I'm just saying don't eat steak every day, all right? And if you can eat steak every day, I need to come to your house, okay? So, but we do. We have more colon cancer here because of our red meat intake is higher than on the coast, all right? They've shown that breast cancer is higher along the Platte, people that live along the Platte River. What drains off into the Platte River? Chemicals. Yep, the runoff, the rain runoff to the Platte. So I don't know what the answer is for curing some of this stuff, the issues that we're having, but I'll bet money there's a lot of issues we have because of a lot of chemicals we're putting on stuff, okay? We have here in Southeast Nebraska, we have more lung cancer. Why do you think that is? It's not the pollution in the air.
Would be the fires?
Huh?
Like the fires?
No? Anybody ever? No? Anybody ever tried to dig in the dirt here? Till up a garden? What kind of soil do we have? Clay. We have a lot of clay in this area, and we have a lot of radon. Anybody ever buy a house and have it get a radon tested or radon mitigated? Okay. because we're seeing more and more radon here. So you'll get people who have never smoked in their life, never been around smokers, and all of a sudden they have lung cancer. And it's like, did you live in Southeast Nebraska? And they're like, yeah. And it's like, okay, we have a really big radon deposit below us. So, and it's like, I mean, it's long ways below us, so it's not like we can dig it up, but that's why we have like radon mitigating things that we have to put in houses now. Okay, so depending where you live depends on what kind of cancer you're going to be exposed to because of the chronic irritation. What do you think Florida has a lot of? Skin cancer, right? Lots of sun, lots of very sun along close to the equator. Sun's pretty powerful. They also are in it longer, right? Because everything set up in Florida is to be outside. All right. We don't have that as much here. I mean, we still have skin cancer, so don't get me wrong. There's different types of skin cancer too. Okay. Some are caused by sun. Some are just caused by a genetic mutation. I had a guy who had malignant melanoma, which is the bad type of skin cancer, on his toe. And I remember I asked him, I'm like, did you wear a lot of flip-flops as a kid? Like, well, how did you get this? And he's like, no, he needs a construction worker. So there's just random things that happen sometimes. So that's the other part of what's the cause. Honestly, bad luck. Okay? So some people, majority of people are getting it chronic irritation. Some people, genetics. And I would say probably more and more we're going to find genetics. We just haven't found them yet. But as of right now, it's 10%. Like I said, that will probably change. Okay. The reason it's important for us to understand genetics and people that get it, because it changes our screening tactics, right? If you have a mom who's had breast cancer, her grandma had breast cancer, great grandma had breast cancer, aunts had breast cancer, or forbid, because men can get breast cancer, so you can have like a brother getting breast cancer, right? You see that in that family happening. You know there's some sort of genetic component. That's going to change when we start mammograms. That's going to change whether we do mammograms at all, or if we go straight to an MRI. Okay, so for people that have BRCA1, BRCA2, it changes how we screen them. Because now I don't want to screen them because I want on a mammogram, because it takes a while for a mammogram to show something. I want to now screen them using an MRI where I can get down to much more detailed imagery. Okay, because why is it so important that we screen people? Why do we want to catch it early?
Because, like you said, those cancer cells, they're growing rapidly, and if you catch it early, it means that
Yes. Yes. The biggest thing that's going to tell you if something is curable or not is if we catch it early. The earlier we catch it, the better we can treat it. We had a friend here on campus that got liver cancer, right? And he's, I mean, maybe 4 or 5 years older than me. And it's like, how did they catch it? And he said, 9 out of 10 radiologists wouldn't have. He goes, I just happened to get the one radiologist that's like, there's a shadow there. There's a shadow there. Let's check it out. I don't know what it is. I don't know what, it may be nothing, but there's a shadow on that liver. Let's check it out. And he ended up having liver cancer. But because it was caught early, that changes the treatment, right? If we can catch stuff early, we don't have to go through chemo. We don't have to go through radiation, surgery, enough. We cut it out, take it out, and it's fine. So it's really, really important that we catch stuff early. If we do not catch it early and it starts to spread, or it gets to a point of mutation that is bad, then we have some really big problems. So that'll move us nicely. Let's see if it'll let me do this. There we go. To now, how bad? How bad is it? Because that's what everyone wants to know, right? As soon as they get diagnosed, how bad is it? Okay? So we talked about catching it early and how important it is to catch it early. The other part that we want to know, oops, come on. Okay, is with catching it early, Somebody found it, we screened it, we found it. There's a couple things that we're going to talk about with how bad, right? And one of them is what we call differentiation. So what relatively good shape is this? It's a ball, right? Right? Nice little ball. Okay, so we know that this is a blue ball, right? It looks like a blue ball. What makes it look like a blue ball? Okay, color, shape, right? Whoop, Peter's throwing things. I'm getting him excited. He's excited about the blue ball. All right, so some days you say things and just realize it, okay? All right, so we've got this blue ball here. We know what it is, all right? Because it looks different than this, right? This blue ball looks different than this. This is the idea of differentiation, okay? Differentiation is how different something looks, how unique it looks to its space, all right? So what happens if I start mutating this ball? Does it still look like a ball?
No.
Can you tell what it was? This now is poorly differentiated. It no longer looks like what it was. Okay, so when we talk about differentiation, it's a spectrum between well differentiated, where I knew what it was. I could see, I could look at it, and I could see what it was. But now, I have no idea what this is. Okay, and cells are the same way, and it goes to poorly. So you'll hear people say, well, the cells are well differentiated. Is that an early sign of cancer or a late sign of cancer? It's early. They can still tell what that cancer is. It has not mutated to the point of not being able to tell. Okay, and that gets really, really important when it comes to cancer treatments too, because then we have to change how we're doing it. All right. So differentiation. So if I have a kidney cell that looks like a kidney cell, and I have a heart cell that looks like a heart cell, although we don't see a lot of cardiac cancers, and I have a lung cell that looks like a lung cell, these are well differentiated. You can tell what each one of those are. You can look under a microscope, you can take a biopsy of that tissue, you could look under the microscope and you can tell exactly what it is. Well, then what starts to happen as cancer starts to mutate the cell and take out the genetics is it starts to change the shape. Okay? And you can still kind of tell. What shapes those are supposed to be. So it's kind of like that kindergartner learning to draw, right? You can still kind of tell what those shapes were supposed to be, but they're not quite there. And that's what happens is we take that biopsy of that tissue, we put it under the microscope and we go, oh, it still has some of the same features of that cell. And then what happens is as that cancer gets more and more, is now we can no longer tell what that cell is. That is bad. That is poorly differentiated. It no longer looks like the structure it was or the structure it is supposed to be. Okay? So that means that they are going to have, are they going to have an increased survival chance or a decreased survival chance? Decreased, right? Because the other problem that happens when these cells mutate, remember the cells around it say, ooh, you don't look like me. You don't look like me, so I'm gonna snuff you out. Well, once we start getting really poorly differentiated, they're like, I have no idea what you are, so I'm just gonna let you keep growing. So those safety mechanisms that our body has to get those glitches out fail because it's no longer there anymore. All right. So then what we get is once we get this tissue, how do we get this tissue? How do you think we get this tissue?
Like how we are viewing it.
Well, how are we getting it? Because these are cells from the heart, the lung, yeah, biopsy. So one of the ways that we have to diagnose people is we have to do a biopsy. The only way we can actually diagnose someone is we have to get some of those cells and put it under microscope. We can do all sorts of imaging testing and go, ooh, that doesn't look right. But until we really have tissue, we do not know for 110% sure that it is. Now, we can look at a scan of the brain and say, ooh, that looks like a glioblastoma, because glioblastomas have very distinct patterns in how they grow. They have, they like to finger out into the brain, okay? Which makes them really hard to treat, really hard to get a hold of. But in order for us to know without a shadow of a doubt, we have to have biopsy tissue. So now if you have an 88-year-old who looks like they have a glioblastoma in their brain, is it worth surgery at that point in time to get that biopsy? Are we potentially going to do chemo on that patient? Are we going to potentially do radiation on them? Hopefully not. But the joke with oncologists that we always said was, why is there nails in a coffin? To keep the oncologist out. Okay? Because oncologists will treat anyone. I remember doing a bone marrow transplant on somebody that was like in their 80s, and I was like, this is not going to go well. They do not have the ability to heal. Now, here's an interesting thing. Who has a better or worse prognosis, young or old? What do you think? Okay, why do you think young?
Their cells are already growing. Like when and then when you get cancer in there with it, it's gonna cause those cells to grow.
Okay, so good prognosis or poor prognosis if you're young or old? What do you think?
For young.
Yeah, for young.
I'd say more
Poor prognosis for young? You're saying good for young? Why do you say good for young?
They're just stronger. They'll be able to handle like chemo and radiation a little bit better than an older person.
Absolutely, right? But you're absolutely right as well. It's kind of a crapshoot between age. Because elderly people, how fast do they heal? Slow. Which means even if the cancer cells go fast, they're still slower than if you're a 10-year-old. If you're a 10-year-old, those cancer cells, they're going faster than what you already do. That's why we see your more aggressive cancers are going to be in your younger people. Okay? Like my friend Andrea who passed away, she was in her 40s when she got cancer, right? So that cancer overtook everything eventually, okay? So it's really, really important. My Uncle Skip, he had a long period of chronic irritation from all his drinking and smoking days. Guess what he died of? Lung and liver cancer, right? So not a shock to any of us, but still sad to lose him. So it's really interesting how age plays a role in how bad it is that if they're younger, they can handle the chemo and radiation better, they can heal from it, but at the same time, their cells are already growing so fast that then it's going to cause problems with theirs are going so much faster than what we can find, okay? So that can become an issue. Also, treatment, every treatment we give for cancer, the side effect is cancer. I've seen the treatment for cancer, every treatment for cancer, the side effect is cancer. So it's which is the lesser of two evils. I have breast cancer patients that would come in and they would come in with leukemia the next time. Okay, because we're giving chemotherapy. Chemotherapy is a cellular mutation drug. That's what it does. It breaks cells apart and it causes genetic changes. There's really cool treatments coming out now where we can give chemo just into the tumor itself. There's really cool treatments that are coming out with getting people to fight their own cancer by creating like antibodies to your own cancer. So we're gonna see a huge shift of more of the biotherapies versus the chemotherapies. So if you're a person that loves history, the Salem witch trials were theoretically because of methotrexate, which is a chemotherapy agent we use. It made them go crazy. It made the women go nuts. It made them miscarry babies because babies were fast-growing cells, and methotrexate is actually a fungus that grows on rye. So women were eating the rye, and they were getting methotrexate in their systems, and they were miscarrying babies. And because they didn't have the science, it was witchcraft. And then because the women were going crazy because they had methotrexate in the brain, and anybody hear about chemo brain, it is a true thing. Okay, when people have chemo, when we're giving them all this stuff, man, their whole body takes a hit. Okay. The other thing we need to understand about how bad is the TNM system. Oops, that's an N, sorry. Okay, the TNM system. What do you think it stands for? No. No. Tumor node metastasis. Okay, so tumor node metastasis. This is a system that you'll see, like when you read a report, you'll see their T is, and they put a number by it. And so you may have a T1, N0, M0. What do you think that means? Right, so they have one tumor, it hasn't spread to the lymph nodes, and it hasn't metastasized. Okay, so that becomes really, really important. How curable is this cancer?
Pretty curable.
Pretty curable, right? But when we start having, let me erase that piece. T1 and 3 M0. Now where are we? Yeah, we have at least 3 nodes that are involved, okay? What we have to remember about cancer is cancer wants to survive, right? We've taken out that self-suicidal cell syndrome, right? Like, I don't know what's really called. I'm sure there's a big fancy name for it. But we've taken out that mechanism of safety. So that cell now wants to survive just like every living, growing thing wants to survive. What's going to happen is once we get into the nodes, you guys, you have like 600 or 800 lymph nodes throughout your body. Okay, the lymphatic system gets very little glory. The cardiac system gets all the glory. The lymphatic system barely gets anything known about it. But the lymphatic system is like a river that flows through your body, and it flows through your entire body. And it is what gets infection out. It is what gets all that waste and drainage out when you get, like, your legs get sore from lactic acid. It's that lymphatic system that helps pull all that waste in and then dumps it into your vascular system so that you can get it pumped out into the kidneys, okay? It's an all intertwined system, okay? When we start getting into the lymphatic system, when we start getting into those nodes, we now have opened up to the entire body. And just like a dandelion poof, when you blow on that poof, it goes everywhere, right? It goes in your neighbor's yard, it goes down the street, it goes to the school ground, it goes to wherever is around you.
Then it grows.
Right, and then it grows. And what does it grow?
More dandelions.
More dandelions. So what's really interesting, and this was a huge aha moment for me, is when it metastasizes, right? So breast cancer, a lot of times will metastasize to the brain because of how the lymphatic system flows. It grows breast cancer in your brain. Okay, why is it important to know the cell origin?
To know where to treat it.
You know where to treat it, true?
And know what it's possible impact.
Yeah. So knowing where it's come from, all right? Knowing, because guess what? Breast cancer is treated very differently than a glioblastoma. So if you have breast cancer growing in your brain, we have to treat it with breast cancer drugs, but we have to get them to your brain because of the blood-brain barrier. The brain actually tries to protect itself from a lot of the stuff we shove in. Okay, and so that's why when we're talking about this stuff that poorly differentiated, we have to figure out where those cells come from. Because that's the other thing. Like you may be going into the doctor because, man, I've been having chronic headaches. And all of a sudden I'm numb and tingly in my arm and I don't know what's going on. I'm scared I'm having a stroke, but it's progressing slowly. And they do a scan of your brain and they're like, okay, well, we see a tumor there, but they have to figure out where it came from. Because you may already have a tumor in your breast that you don't know about that's spread to your brain. Or the breast may have spread to the liver, okay? Or bones. Breast cancer likes to go to bones a lot because your rib cage is right there, okay? So that's what we see. Your breast cancer, it gets into the like your sentinel nodes and stuff like that. So that's why you'll see people do node biopsies along with tumor biopsies. Is because they need to know if it's in that node. So that lets them know how far that dandelion poof is now flying. Okay, I've had the patient that had malignant melanoma in his big toe, it was showing up on his liver. It had traveled that far. So then we start getting, you might start seeing, let's see. T1, N3, that probably actually would be a bigger one. This would probably be a 4 because the T is actually the size of tumor, not necessarily just the numbers. It can be the numbers or the size. All right. So if you have lots of tumors in your liver seems to get a lot of them. It may be the number of tumors that you have in your liver, but it also might be you may have one really big one in your liver. Okay. So now what do we have going on with this T4, N3, M2? Yeah, so we have either a really large tumor or we have 4 tumors in the spot of origin. We now have seen it in 3 lymph nodes, and now we have metastasis in 2 areas. Now, how's our prognosis? Really bad. Okay, and so this is why it's important for us to understand these 2 things, not just the differentiation, but also the TNM. You'll see it as you're reading. If you read a history and physical, sometimes you'll see doctors have that in there. They'll have both of these pieces in there. It depends our treatment. My friend Andrea, who had breast cancer growing in her brain, we had to put a port in. They had to put a port into her brain to give her chemo directly into her brain. Okay, it bought her time. That's when you start getting into the idea of palliative chemo, palliative radiation. It's buying you time. It's not curative, right? They're not going to try and cure it. They're going to try and understand it. Okay, so this is something to get you guys started as you're going into our cancer stuff. This is how it is for every single cancer. Okay, some of them have different specified or specific, like tumor scales with the TNM. Sometimes they'll start adding other things onto the end of it or something like that. But that's when you're really starting to dig into your oncology patients. But you'll see this as you go through. But the differentiation is really, really important for us to understand because it understands why it can be so hard for us to find the tissue of origin. Like a lot of times they'll be like, it has metastasis, but we do not know where it originated. That means that tumor, wherever it originated, is still there and it's still throwing out seeds. It's sort of like when you take care of your yard with dandelions, but the school down the street doesn't. Doesn't matter how much you take care of that one space. That school dandelions are coming all to you. And every day at recess, the kindergartners are all out there blowing them off, right? Or beating each other on the head with them or whatever. So they're going everywhere, okay? It makes our treatments understandable because our treatments all go after the fast-growing cells. What are the fast-growing cells in your body? Not quite skin, but something specific. Okay, so our fast-growing cells, what do people lose when they go through chemo? Hair. I heard blood cells. What tissue? Not all of our cells are fast-growing. There's specific ones that are fast-growing. Hair, blood,
Skin.
What happens when you bite your tongue? How long does it stay sore?
Not too long, but they quickly do.
Right, usually a day or two, right? You burn the roof of your mouth with cheese, right, from your pizza. Okay, done it several times, coffee, whatever. It stays sore for that day. Maybe the next day it's gone. Your mouth and all the way mouth to rectum, those cells are very fast growing cells. So your mucus cells. Okay,
Would you say those types of cancers are like the worst because
it depends on worse, because when we're talking about the idea of worse, like you can have a very small tumor in a very important space. Like my grandma died of hydrocephalus. What's hydrocephalus? Fluid on the brain, because she had a 5 millimeter tumor. So like teeny tiny tumor on the ventral duct. She was 90 years old. She chose not to treat it. Versus you can have big tumors in your belly. Why do we get big tumors in our bellies? Bigger area. It's a bigger area. It's squishy, right? If we went to the doctor every time we were bloated or had a distended belly, man, I'd probably be there once a week. Okay? Like, I mean, think about it. Like people with ovarian cancer, pancreatic cancer, liver cancer, colon cancer, they become very, very big tumors because no one catches them. Because it's big, squishy space. Our brain, not a big, squishy space, so tumors there tend to show up a little faster. Okay, so it's about, like, when we're talking how bad, size doesn't always matter. Location can be very important as well. If you have a tumor that's putting pressure on your aorta, it can be a small tumor, but if it's putting pressure on your aorta, what are you impacting? Your blood flow. Your blood flow to your brain, your blood flow to your body, you're impacting all of that. So we can have, that's usually when we start finding our abdominal tumors, is when it pushes on something. Kind of an interesting fact about cancer, it does not hurt. Cancer does not have nerve receptors. It doesn't hurt. Okay, but what causes the pain? The treatment? What else? Huh?
The pressure. Cells growing and.
The pressure. The pressure of what it's pushing on. My grandma's brain tumor didn't hurt. She didn't have headaches because of the tumor. She had headaches because of what it was pushing on and what it was causing. So when people start having pressure and we start having pain from cancer, it's because of what stuff is pushing on along with treatments. Treatments can always cause pain. Okay? So things that we have to think about as we're starting to think about this. If anatomy is not your specialty, I would make sure you are looking through your anatomy textbooks to think about, if I had ovarian cancer, what is it pushing on? Okay? Because that changes your symptoms, right? If I have a neurocancer, what is it pushing on? Because that cancer is going to change your symptoms versus a liver cancer. With liver cancer, what labs would I be looking for? Not granted. Your AST, your ALT, lipase, all those liver enzymes, okay? That's what we have to start thinking about, because I'm teaching you big and broad. Now you're going to have to apply it to the individual patient. If you have somebody with renal cancer, what are you going to think? What's going to hurt? Their back, right? They might also be peeing blood. If you're peeing blood ever, it's probably a bad sign, okay? So that's what's really important. Your creatinine and your BUN are probably going through the roof, okay? Your white count might be skyrocketing because you've got, like, so that's the thing. With cancer, it's all the same. It's where it's located and what it's doing to the body. And that's how it changes. The tumor is still a tumor. Whether it's in the liver or the brain, it's still the tumor. It's where is it pushing and what symptoms am I going to see that are different between liver cancer and lung cancer. Okay? We have to be able to start putting those things together. All of the treatments are going to be the same. All of the treatments are going to attack fast-growing cells, which means we are going to have problems with all three of these things: hair, blood, and mucus, our mucous membranes. Okay? Because those are all fast-growing cells. If you were pregnant, we would have a big problem because babies are rapidly growing in your belly. Okay? That's why some people will opt not to go through chemo while they're pregnant, and they'll wait, and then they'll go through chemo after they have their baby, or they might have to decide if they want to try and save their life. They might have to decide to terminate the pregnancy so that they can go through chemo and save their life, and then hopefully be able to have a baby again. I would not envy a person that had to make those choices. That would be very personal and very unique to situations. Okay, but you can't go through chemo. Some chemos, the placental barrier will take care of, will watch, and they might be able to do that, but not all. Okay, so something to think about. Thinking about the different size, the different locations, how it changes in your patients that you're going to start seeing. Okay. There is a podcast for you guys to watch or listen to. Sorry, it's a little long. It talks a lot about the cancer warning signs, which spell out caution. I would make sure you know those. It talks about these fast-growing cells and the different things that we have to worry about with each of these issues. And it also talks about some emergencies that happen with cancer patients. So there's definitely emergencies that happen. You guys won't take care of a patient that is like at the chemo center getting the infusion, but you sure as heck will see people coming back from chemo coming to you, or you're giving them oral chemo or something like that. So you will see these patients. You may see them as they're coming to rehab and they're trying to build up their strength again. Okay, so it's important that we understand the different cancers, where they're located, and then the treatments. But the treatment goal for all of them, if we can catch it early, we can cut it out. If we can't catch it early, we have to start doing radiation and chemotherapy. Okay. All right. Any other questions? Sorry, that was kind of a crash course on cancer today.
I kind of have a question.
Okay.
If somebody's going in for cancer treatments, like for an example, is my great uncle, he's just finished his last radiation like last week. But in the beginning, like he's going in like 4 times a week to get his blood checked.
Yeah.
And before, like they knew that he was having high blood sugars, basically.
Yeah.
And he wasn't feeling good one day. And his blood sugars was 500.
Woo. So he's pumping some sugar in.
When people are looking at their labs like that, shouldn't they know, like, not something that they